I'd just like to see a show of hands. How many of you are researchers? If you just put your hand up. A good number of researchers. How many are arrogant researchers? No, not too many hands, just a few. How many of you are policymakers, please? Fewer policymakers, that's good. And how many of you are funders? Just, well, translators, but defining translator, that's a tough one, so we're not going to do that. Okay, that worked. We got you to sit down. And we learned that there's a mix, but a lot more researchers than others, which is interesting. Especially because the next panel is a group of researchers. And also interesting, they are reactors. And that's kind of intriguing because to me it suggests something about the dynamic. I didn't think about this before a few minutes ago, but the dialogue that we're talking about between funders and researchers and policymakers is challenging in part because of the fragmentation and the siloing that we all suffer from in our own worlds, but also across these different worlds. And the fact that these guys are reactors rather than partners is kind of interesting. Probably not the best way to frame it, but I think it's probably an accurate way of framing it for the moment. So just a couple of comments before we ask our panelists to speak briefly and then hopefully have some vigorous dialogue. I'm excited to be here because, oh, sorry, I'm supposed to introduce myself. See, I'm just a facilitator. I'm David Scher, the facilitator of the reactors, and I'm from Blue Cross Blue Shield, and I actually work with some of these researchers, so which is why I read the research reports, because I'm supposed to be their partner. In any case, I'm excited to be here because I love being in Michigan now. I think there's an extraordinary amount of exciting thinking going on and good work. I think we're very fortunate. We have this rich, fertile environment where we are actively not just tinkering around the edges with pay for performance and public reporting, but we're actually engaged in achieving some tectonic shifts in the healthcare system, moving it towards a high-performing system in meaningful ways. Fertile ground, a rich environment in which to study, not just to generate evidence-based practice, but to begin to reframe things and think about practice-based evidence being used by folks actually providing care. And that reframing of things might help us think about how we actually bring the research and the funding and the policy worlds together more effectively. The current paradigm is more research as a separate, rarefied thing. It filters down over a period of a decade and a half. That doesn't work well in the real world. So I think there's a lot of animation in the community broadly, and I think we'll see that evidenced in our panelists, our researcher panelists, who are each going to speak for about 3 to 5 minutes. They're going to keep it very brief, and then we're going to open it up to hopefully a vigorous dialogue. And we'll start with, I'm not going to introduce them other than to say first Skip Campbell, Mark Fendrick, Gary Freed, John Pate, and Fred Blow, whose bios are in your materials.
Okay, should I start, David?
Please.
Okay, let me turn this thing on.
They will do it.
They'll do it. Okay, good. Well, it's going to be hard for me to do this in 3 to 5 minutes. I love talking about this subject. I am a professor, so in that sense I'm a researcher, but my research has shifted over the years from the wet lab to the community hospital bedside, and I think that's what I have to offer to the research community at this point. I have a legitimate place standing at the bedside in an average community hospital, and that's through my group, which is the Michigan Surgical Quality Collaborative, which has been generously funded by my friend and Tom Simmer, my friend, for a lot of years. But that group has about 60 hospitals in Michigan at this point, and they're almost all community hospitals. So I have this access to what really happens in the real world as opposed to what I hear happening at the American Surgical Association meeting, which I don't think is the real world. And that gives me a lot of information that I think can be helpful in this dialogue that we're talking about right now. So I'm going to summarize in a very short period of time what we do. We establish a registry that's consistent and has standardization to it. Then we examine the variation in quality using that standardized registry through the 60 hospitals. I'm a surgeon, so this is all surgical stuff. And then we identify the best performer. We make site visits to the best performing hospitals, and we stand around and kick the tires and ask them what they actually are doing that they think is valuable, and then we disseminate that information to the rest of us. And that, in a nutshell, is what the Michigan Surgical Quality Collaborative does and what many of the other CQIs do. So that, now, to get to, that has been successful, and next Tuesday, Blue Cross Blue Shield, and I don't want to steal their thunder, but they're going to make a big announcement about how much that improvement in quality and in surgery, it has to do with the avoidance of very expensive complications that cost somebody money. And they will make an announcement about what they think that number is, but it's a very big number. So it's been, that process has been successful at the community hospital level. So the next phase, and this is where I get to this idea, my idea anyway, of how we can speak the same language, is that we've been speaking the language of quality, which is fine, to the community surgeons, but now we have to shift that to speak the language of value, and that value being quality divided by cost. And they don't necessarily think of that, and we haven't been able to really push that issue because we didn't have the right kind of data to do. And now we do, again, an amalgamation with the Blues, because they have the cost data and I've got the quality data. And so if we link those, we then are able to show the individual hospitals a grid. And the grid is in 4 quadrants. And one quadrant is high quality, high cost. Another quadrant is low quality, low cost, and everything in between. And so, you know, obviously we want to be in the high quality, low cost. That's what the president has asked us to do, improve quality and reduce costs. But when we find those few hospitals that are in the high quality, low cost quadrant, we then make an effort to make site visits to those hospitals and add that new dimension of cost into what we're analyzing. And I think that gets directly to a language that policymakers and researchers can have in common, dollar bills and quality. And that, to me, is the direction that we need to go in our effort. So I'll stop there. That's 5 minutes, David.
Thank you. Mark.
Good morning, everyone. I'm Mark Fendrick. I'm a professor of internal medicine and health management and policy, and I direct the Center for Value-Based Insurance Design here at the University of Michigan. It's a very, very, very strange path that I've taken to be sitting here to talk about the interface between research and policy. And the fact that over 10 years ago, Dean Smith, who's here in the audience, Mike Chernew, who was mentioned by Karen earlier, and myself came up with a typical academic idea about how to redesign health benefits to achieve a lot more health for the money we're spending. And I'll tell you at the end, as I get to the beginning, is that this idea is largely driven by the private sector, was moved into the policy sector, ultimately included in the Affordable Care Act explicitly, especially in the element of the law that is one of the most popular in the fact that it removes patient cost sharing for high-value preventive services, which is the basic premise of value-based insurance design, that you make it easy for individuals to get the services that produce the quality that people like Skip and others would say. It turns out that although the Affordable Care Act, aka Obamacare, is often spoken with highly partisan tones, this aspect of the law polls very highly both among Republicans and Democrats, as long as you don't tell them it's part of the Affordable Care Act. And a recent report from HHS and the Kaiser Family Foundation suggests that 45 million Americans have already benefited from the reduction in cost sharing for things like pap smears and colonoscopies and screening for obesity and smoking cessation and other types of things. So I think that I finally have something to put on my tombstone, in addition to the fact that I hopefully was a good father, husband, son, et cetera. A couple reflections on the morning as opposed to how an academic and tying into the funder and the policy aspects. I think the first and most important thing is that academic currency, that being funding and publications, does not support policy efforts, period. And I think that one of the major exciting parts about our new IHPI is that maybe we'll open our eyes to reward not senior faculty members who sit on this stage, but junior faculty members who want to go beyond doing basic research in their areas, but actually do implementation, going beyond that publication and actually make it happen. Eve mentioned publish or perish. I'm very quick to tell every stakeholder group that I published and I still perished. And it was because of the efforts that I'll get to in a second to move beyond the funding stream and the CV promulgation that leads to promotion and tenure for most of us, the researchers who raised our hands, to actually step out of the box. I'm very lucky to sit on both sides of me, two individuals who have been able to parlay a major policy effort into academic currency. Both Gary and Skip, as you heard, 30 publications from his efforts and hundreds from what Gary has done studying child health issues in underserved populations, Medicaid populations, and the like. But most of the work that I have done has allowed me to step away. I haven't written a serious research grant in many years, and most of the publications I write are following the advice on Marianne earlier before, 2-pagers, 1-pagers, briefs, no longer being extraordinarily concerned about New England Journal of Medicine and the Journal of American Medical Association, which my department chair and dean cares more about, but focusing a bit more on that Wall Street Journal of Medicine and the New York Times Journal of Medicine that David Gifford talked about earlier. The most fun for me to talk about this, and I won't go too long, is that if you decide to step out of the box, the researchers, and you want to move forward, don't think that you could do it by yourself. And listen to David Gifford. Don't think that people are going to call you. You must be proactive. And you have to find an advocacy expert, because the skills to make this happen are not the things that we learn. And I'll just tell you briefly that the advocacy expert I dealt with was so great I married her. I don't suggest that you all do that, but whether it be the medical school with Rick Bossert, or the School of Public Health with Jen Martin, or the School of Engineering, or the Public Policy School, most of you don't know there are actually people who have expertise in those places to allow you to move your ideas forward. And they're often underused and they're often underappreciated, but they know this web and unorganized way to get your idea into Lansing or Washington or wherever else you go. My personal experience with policy before I had my first trip to Washington was Schoolhouse Rock. And I could still sing, I'm just a bill, I'm only a bill, but that's it. And here is value-based insurance design is included in the 2,700 pages of the Affordable Care Act. A few other closing points. One is research is necessary but not enough. And since David used the term arrogance, don't assume you know everything, because that is the reason why John Pate's wife rolled her eyes when this PhD came in here, because it's a typical arrogant situation that we speak down on individuals who don't have time to read all our stuff or don't have the wherewithal to get the resources, so you have to be very, very patient in that regard. Another point which I'd reiterate from the academic side is follow, charts lead, and distill and translate. And one of the things that Tracy Swinburne, our center director at VBID, is taking the many publications we have written around value-based insurance design, written for academics, and putting them down into 2 and 3 pages that policymakers like Senator Whitmer can read. And maybe Tom Zimmer would actually read every now and then if we gave him in a 1-pager as opposed to the boring 8-page health affairs article and not make his eyes go bad as he's showing us here now. Another quick point is appreciate the breadth of the agenda that a typical policymaker has to think. They're not only thinking about health, they're thinking about transportation, they're thinking about education on the federal level, thinking about defense and other types of things. And a lot of this has to do, I think, with the fact that a lot of this aspect moving forward has to do with a couple things. One is most visits to policymakers that we don't make are not educational. Right? Most people are going to see a policymaker with what the people in DC and Lansing call the ask. I did not know that the word ask was a noun until Jen brought me to DC 6 years ago, right? That most of these meetings people have an ask. We were very fortunate to basically have an idea that we wanted to promulgate, and because healthcare reform was on the table, people were willing to listen. And that's my closing point. Patience, timing, and probably the number one predictor of our success nationally is just luck. And some of those things you can't control.
Thank you. Gary.
Thanks. My name is Gary Freed. I'm also at the University of Michigan. I'm a pediatrician, and I direct something called the Child Health Evaluation and Research Unit, which is a pediatric health policy and health economics research center focused at the University of Michigan. If you had to ask us what our overarching goal is, and I'm going to tell you a couple of stories to help to illustrate that, it's to make a difference in the lives of children, which sounds just very trite, like, right, that's a reasonable thing to want to do if you work with kids. But to try and do that in a research sense and in a policy sense requires, I believe, a very different perspective than what I think a lot of researchers at the University of Michigan and other places actually have. we have a few sayings. The first of which I want to share with you is, if I say that if Yogi Berra was a health services researcher, he'd say if you want to be relevant, you have to be relevant. And that means that you actually have to deal with issues that people care about besides yourself. When I came to the University of Michigan almost 14 years ago now, I came from a different state, the state of North Carolina, where the state university actually looked upon itself as an organ of the state. When I came to Michigan, I also believed that this was the University of Michigan and that we had a special responsibility to the children of the state of Michigan, and that was going to be a focus for our work. When I went to Lansing with the help of Rick Bossard, the government relations officer here, people didn't believe me. They thought, that's not what the University of Michigan is all about. What are you talking about? And I wanted to develop a relationship with our state and with our state Medicaid program and with other aspects of our state healthcare system that was going to be able to provide them timely information on issues of importance to them, not necessarily to me, that was going to help them make better decisions with regard to policy and implementation of policy for the state. One thing we forget about when we talk about policy is that's only the first part of it. The way in which policy is implemented is highly variable, and people have a lot of choices about how they're going to implement policy. Understanding what happens when they implement policy, or the potential choices they have and the implications of each, help people make better decisions. So we wanted to be able to provide that information because there was no source of that kind of information for people at our state. We also wanted to make sure that people realized we did not have a political agenda. We were not advocates. Sometimes advocates love what we do. Sometimes advocates hate what we do, even advocates for children, because really they're advocating for their own positions for children, not necessarily always for children. So one of our other sayings is people don't know our politics by our data, because we wanted to be trusted whether or not there were Republicans in the governor's office or a Democrat-controlled legislature. And over the 14 years I've been here, all of those things have shifted. But what hasn't shifted has been the state's commitment to fund us to be able to provide them specific information to help make better decisions, regardless of who is in power. That's a key concept. Now, I understand that certain researchers do mix their advocacy with their research, and that's certainly one way to go. But I think it's a successful model also to think about being able to bridge those gaps between the different legislators, because if people want to have a debate, and all of healthcare is political. I mean, that's just the way it is. And most of the times the debate that goes on is really just on rhetoric. However, we believe, sometimes naively, but not always, that the debate could also be focused on information to help inform that rhetorical debate. And again, that's at the political level. At the administration level, as people still have to implement whatever laws are passed, providing real unbiased information that they can trust helps them to do it. As soon as anyone in Lansing or in Washington, and I'll give you an example in Washington as well, says that, oh, that cheer group, they always say that we should blank, that's the day we're worthless. That's the day we lose our funding. We can never go down that road. The other thing that's really key that we promised to these people in Lansing and also in our federal government was that we would be on time and on budget. Now, that's blasphemous to most people in academia because we are masters of what we call the no-cost extensions. But you know what? If there's a hearing on November 11th and there's data and there's information that need to be promulgated or addressed at that hearing, the fact that someone in my group can do a few more regression analyses and have it really pretty by November the 16th makes that information irrelevant. So people have to know and be able to trust you that you're going to be on time and on budget. And that was very key to us. The other aspect of this has been at the federal level, and I'll give you just one example for that, and that's at the CDC. There was a lot of issues, and still are, that go on with immunization policy and financing for this country. We're the go-to place for the federal government for those kinds of studies. Now, this didn't happen overnight. It didn't happen because we had a lot of talented researchers. That was only part of the issue. The issue was we would write these really great grants to study these issues that were in the newspapers every day. And you know what? By the time we wrote the grant, waited for it to get funded, do the research, and find out all the results, we had beautifully elegant, wonderful answers to questions that no longer existed. Because that policy thing happened 2 years ago when we wrote the grant, not when we had the results. So we had to figure out a mechanism to be able to have wonderful, elegant results that would actually be relevant, to go back to my Yogi Berra thing. So we actually worked with the federal government to have us on retainer because they could trust us to be on time, on budget, unbiased, so that when they had issues in which they needed information to help make decisions, we were the people they could come to in real time to get those things to occur. It doesn't mean we ignore the academic productivity aspect of things. We're a public university. We publish everything we do. I would put our publication record up against any group in this university. But we do it in a responsible way. We don't do it with an agenda. And we let people in the government know and get their input on what those results really mean. Because we, the arrogant academics, want to bash people and make them look stupid. But that's not the way you're going to build a lot of relationships going forward. The last thing is, I think it's really key, is that just sitting, we like to say that, you can do a lot of interesting things, but interesting doesn't really make a difference. It's got to be interesting and relevant. And that also means, for those of you who said you don't read, medical journals, yeah, we publish a ton, but you know what? A lot of stuff ends up on a shelf and no one reads it. So we actually put out press releases on probably 85 to 90% of the articles that we publish. And so we are in the press constantly, in the Times, in the Washington Post, in the Detroit papers. And I would say any time now that you read anything to do with health policy or health economics research in this country in any of those papers, probably 25 to 30% of the time it's come from here. Not because we're doing the most amazing thing in the world, because we're doing some good things, but because we seek to inform public debate. The information buried in our journals are relevant. So I think you can make a real difference, but I think you've got to plan and be very deliberate in trying to do it.
Thank you. John.
To avoid repeating many of the great comments that have been said already, let me try something specific. I'm going to speak specifically to the 3/4 of the people in the room who are researchers. The rest of you are welcome to listen in. This is a really difficult time for you, especially if you're an academic researcher. Funding is unstable, it's uncertain, it's changing a lot. We can say, and I totally appreciate the sentiment of President Mary Sue Coleman when she said it's not publish or perish, but in fact for you, especially if you're a junior researcher, it absolutely is publish or perish. You have to keep doing the things that you were expected to do for many years, but now we're expected to do more. So that's a big challenge. It can be very, very discouraging. I get that. Many of you who I talk to, who are you researchers, especially junior researchers, are scared, you're worried, you're feeling that your role and your unique contribution that you work so hard for is being undervalued. And that's a problem. But, it really is a time when that's a situation we're in. It is a time of great change, and there are some opportunities. Some of us, as researchers, certainly are arrogant. It's not necessarily a benefit, but in the academic environment to be arrogant, but it doesn't hurt either. The environment tolerates a lot of arrogance. Many of us sound arrogant, though, just because, among us in private, we're very nerdy. And so we speak in a very non-natural way about what we do. And we do get very excited about what we're doing instead of really connecting with people about the core element. Let me give you an example. You might be studying care management, telephone care management models for heart failure patients. But really, you got to think about it, and the way I talk about it with my own staff is what we're doing is we're trying to help people here in Michigan who are very, very sick. It's hard for them to get out to the doctor. They're worried about their health. They don't know what they eat, and they're suffering. And that's how, I work on my main appointments in the VA. That's how I think about the VA. The VA is a healthcare system that treats patients that live really far from where they get care. Many of them don't have access to any other healthcare system. They're worried all the time. In the winter, they're worried about the heat getting cut off, about the car not running. It's a lot of suffering, and our job is to relieve that suffering, and we're trying to do it with knowledge and our unique scientific skills. That's a really different frame, and it puts you on a common footing that I think will give you more enthusiasm to do your work and to connect with policymakers in a different way. There are some, experiences that you're going to have when you go out and try to talk to policy makers, get out there in the real world. They're not all going to be positive. There are policymakers and organizations and administrative units and God knows federal and statewide governmental organizations that can be dysfunctional, incredibly dysfunctional. There's constipators, that people that are very territorial, that are people that will have that prejudice against you as an academic and call you that PhD, the way my wife used to use the term. But move on. Everyone is not like that. There's some very, very enlightened people, at the risk of sounding obsequious. Dr. David Sher is one of those in Blue Cross Blue Shield. Him and others in Blue Cross have really done amazing work at transforming care. They exist, and they're at all levels. You've seen some of them up here today, so continue trying in that way. There's some, the policy of, or the new area of implementation science was really meant to address this gap that we're talking about. It had a rocky start to my mind. There was a lot of fumbling around. Are we doing implementation? Is this science anymore? We tried to submit grant applications to NIH and they'd get torn apart by our fellow reviewers because they'd say this isn't science at all, and sometimes they were right. But the science has really evolved, and under David Atkins and Query in the VA, even if you're not in the VA, Google it, Medline it. There's hybrid models to where you can test the efficacy and effectiveness of something while actually studying if it's scalable and implementable with a reasonable budget. It's very novel and exciting, and there's some ways to do that. On the more rigorous in the sense of randomized trial end of the spectrum. There's adaptive randomized designs that you can look at that are trying to look at how you can tweak things along the way policymakers like to do, rather than leave it in place for 5 years and then realizing that it didn't work at all. This fits very well with personalized medicine. This fits very well with some of in my own area of mobile health, machine learning, artificial intelligence, ways of making things adapt. So, keep your eye out for these new models, scientific models that are allowing us to do the things that we need to do and that we like to do in terms of rigorous academic research, while addressing some of these concerns about us not being relevant. And my final comment is, what's been raised before about publication. As I said, it's going to be important if you want to live in an academic environment. My personal bias has been sort of exactly consistent with what Mark has said. I have never had a paper in the New England Journal of Medicine. My papers have all been tiny clues to a big picture. I say publish a lot, not worry less about the journal. If it's in Medline, people are going to find it. And all of those things come together in terms of a body of work where you'll be respected and recognized in your academic environment, and people will find you out in the real world and use what you do.
Thank you. In the spirit of speaking the same language, what does obsequious mean? Just kidding. Thank you. And Fred next.
Good morning. I'm Fred Blow. I'm professor of psychiatry, and I direct the mental health services section in the Department of Psychiatry. But I want to spend most of my time talking about my role in the VA. I direct the National Serious Mental Illness Treatment Research and Evaluation Center for the Department of Veterans Affairs, and I'm also a investigator in the Center for Clinical Management Research here in Ann Arbor. And my center in the VA, SMITREC, focuses on very broad policy-relevant issues. I directly report to the Director of Office of Mental Health Operations, which is the main element in the VA that provides services in our 139 facilities and about 700 community-based clinics nationwide. I also have direct links to the Office of Mental Health Services, which is the policy branch of the VA. We do a lot of work related to monitoring care and establishing various benchmarks for care for people with mental disorders in VA. We run the National Psychosis Registry, which is a comprehensive registry of everyone that touches our system with a psychotic illness. It includes all pharmacy, all utilization, and a variety of other data sources. We also have the National Registry for Depression, a similar national registry that allows us to monitor care for people with depression nationwide. We have been very active in primary care mental health integration. We're the lead evaluation center for evaluating primary care mental health integration in the VA. Is 110 programs nationwide, and we do a variety of work around primary care mental health integration. We also do a lot of other kinds of research. I wanted to focus all of my comments actually on our suicide work. So we are the national evaluation program for monitoring suicide in the Veterans Health Administration. And we've been doing this since 2006. And we have to just put this in context. We have about 8 million enrolled veterans in our system. About 5.5 million people access our services every year. Suicide is a national health crisis. We need to be really aware of it, and we need to do very serious things around dealing with it. The work that we got involved with really was stimulated by returning veterans. So veterans returning from Iraq and Afghanistan seem to have higher rates and higher risk for suicide. And back in 2006, there was huge initiatives in VA to expand our ability to prevent suicide, to aggressively pursue suicide, to understand suicide. So we had the great opportunity to be the lead in evaluating and monitoring suicide for VA. And so for the first time in the world, the only national health system that's been able to link all of our utilizers, our veterans, with the National Death Index cause of death file. So we have a 100% match of all deaths that occur within VA. So we can determine with fairly good certainty the number of and percentage of suicides. So we were able to establish that, for example, the rates of suicide among veterans who use our services is about twice that for the national average after adjusting for age and sex. We're able to establish that there's tremendous regional variation, like there is tremendous regional variation in suicide around the country. Those things were important early indicators of how were we doing in terms of monitoring suicide and actually changing the potential for increases in rates of suicide in VA. But they weren't sufficient in doing that. We then explored many, many risk factors, trying to understand risk factors for veterans, and I would argue for people in general, because we're really informing how we might think about suicide prevention for the nation as a whole, not for the Department of Veterans Affairs specifically. And so many things this morning sort of play into or I can really identify with that we've been pushed to think about, which, for example, clear, actionable steps. So while we can say we have high rates of suicide and that most of the suicides are from firearms, about 85% are firearm-related suicides, that's not sufficient to do much about it. Well, so how do we think about that? So we have published probably 45 papers on this topic to date. But that's not sufficient either. While it informs the field, absolutely is important for validating what we're doing and publicizing what we're doing and maybe helping others point the way to new ways of thinking about this, still not sufficient. So as we've been pushed to think about this, we have issued 4 very brief clinical briefs that were results of the analyses we've been able to conduct. These clinical briefs went out to every provider in the Department of Veterans Affairs. They related to the high risk for suicide among people that have traumatic brain injuries. New information, no one knew this. There was no validation of this in the literature. New data on people with depression that are under age 30 returning from Iraq and Afghanistan having astronomical rates of completed suicide, able to directly, within a month of having the results, putting out a clinical brief to implement the risk for providers, or so providers could understand the risk. We've also been really interested in pain and suicide, and found that in our data that people that have chronic pain have much higher rates of suicide, another clinical brief that we put out. And then finally, more recently, just last month, we had a clinical brief among people that are discharged from nursing homes have much higher rates of suicide if they get discharged from a nursing home, and we need to be really aware of that. Still not sufficient. While we send out these clinical briefs and have direct relevance to clinical care, we still need to do more. And so I've had the fortune of briefing the Undersecretary of Health nearly on an annual basis on these data. The question always comes up, so what else can we do? Every life is a critical life lost. Every suicide is a suicide that shouldn't occur. So how can we do better? And why are our rates still the highest of any healthcare system we know about? And the data are sketchy around that. But how do we do better? We identified in some other analyses we've done that there's a high risk period for suicide, post-hospitalization for a major depression episode. And that risk period lasts for 30 days. A new policy was implemented requiring a 30-day recontact of every individual that comes to us and that is discharged from hospital. We don't know if that's going to have an impact, but we are monitoring that. We're now going to be able to actually determine whether or not that has an impact. Another thing I've learned in all this process as we've had to inform policymakers, but also having to really directly try to impact clinical care, is that presentation really is the key. Someone mentioned that earlier. We need to give information that's consumable, that's understandable, that is on point. So when I've testified before Congress, the question always comes up about, so what do these data mean? It's what rate per 100,000 what? We really have to be very clear and sort of distill this down to whatever audience that one is really targeting and focusing on. Without that, we really, I think, miss the boat and miss opportunities for communicating key results. The other major thing that I think I've learned from dealing with policymakers and Congress and my work with clinicians and clinical leaders is that people do want solutions. People don't just want, here's another thing we found that is another risk. They want us to be thinking about, so what could we do? So remember I said that the rates of firearm suicides are very, very high in VA, 85%. What could we do? Well, we established a program to distribute gun locks to people so that you could have some gun safety. Educating people about gun safety potentially could have a major impact. We've done some other work trying to figure out, could providers have a dialogue? We've done some qualitative work. Could providers have a dialogue about safe storage of guns and thinking about gun safety in that way? Politically charged, very complicated things, especially in the Department of Veterans Affairs, yet really important to do, focused on solutions, focused on things that can be done that's actionable. The last thing I wanted to say is that it's still not sufficient. So I've talked about our 5.5 million veterans we serve every year, and we suspect that suicide rates are higher among people seeking our services in the Veterans Health Administration. But that's only a portion of all the veterans who've served our country, 22 million veterans nationwide. And we know that veteran suicide is high across the country. We've done some separate analyses using the National Violent Death Reporting System to try to disentangle the people that use our system compared to those who don't use our system. And the rates are higher among people that come to us, but they're not that much higher. So we have the complication about, well, what about everyone else that potentially has high risk? And that's where our work with the Department of Defense has come into play. Very complicated. You'd think the Department of Defense and Department of Veterans Affairs would actually talk to one another. Wrong. And so we've had a lot of dialogue about sharing data, sharing attempt data, sharing suicidality data, sharing multiple deployment data, lots and lots of things. And that's a different policy discussion. So I think that what I've learned is that there are just many constituencies up and down the sort of levels of policy and clinical delivery systems that we have to really focus on the different segments of that and target our information, target our approaches to the specific levels, or we really miss the boat. They get glassy-eyed very quickly. As academics, we want to give the ultimate little details about our methods and how good quality it is, and what we're doing is really very, very fine. But in reality, what people want to know is, what can I do?
Okay, thank you. So thanks to all the panelists. So rather than me asking them questions to get things started, and in the interest of trying to gain further insight into the barriers that keep the various constituencies gathered here together from working together, partnering rather than engaging in parallel play, and, as we tend to do, and in the spirit of a common purpose of, in John's terms, relieving suffering, I'd like to just ask the audience to help lead this part of the discussion. We have about, well, it depends if we're going to stop right at noon or not. Our overseers will tell us that. But please stand up, go to a microphone, and engage with the panelists in some dialogue, please.
So as researchers, presumably you sit on promotions committees. And so what would it take to reward academics for impact rather than number of publications? You know, how far are we from changing that discussion, and are there things that we could do as funders or other people could do so that the person who has a couple of really high impact publications is viewed upon as favorably as someone who's had a stream of more grant funding and more publications, but hasn't really stuck with something as a champion?
That's a great question, and that really calls out an important barrier within the academic world. Let me ask the panelists to keep their remarks really brief. You don't all have to comment on everything because it's already nearly 10 to 12. So, but these are important issues, so we do want to touch on them in a meaningful way.
So I'll start and be very brief. The junior faculty members who've come to me and wanted to go into policy are the ones who explicitly say they don't want to go into academia. So just highlighting the problem, David, that you mentioned. I've thought a lot about this, and I tell you I have no answers because I've been introduced to Congress as the shallowest guy in academic medicine, and most of the people who around here are super subspecialized in an area, and this would have to start a dialogue almost de novo in terms about how we rewarded clinicians for excellence, how we awarded teachers for expertise and excellence in teaching, where in the medical school I went to, if you won the teaching award, you were let go because your research wasn't going so well. So I'm glad for you to I'm glad for you to plant the seed in this to just reiterate what I've been talking about for quite some time, in that there is a clear dichotomy. There is no reward for successes on the implementation stage, at least in the situations that I've been in, and it requires a dialogue right from the beginning.
I would add to that that if I was on the promotion committee, and admittedly this is sort of pie in the sky, but I think that I would look to areas, and everybody has to have a niche, we agree on that probably, but the areas that people have not gone before is the most attractive part of it. And building on my previous comments, I think that there's areas in surgery where just nobody goes, and one of them is appropriateness. That's something that I think should resonate with policymakers. But it's hard to make an operation higher quality if you didn't need the operation in the first place. And so that's one area that I think is very important. And the second one, John mentioned, the whole idea of implementation science, which I think is an area where surgeons just don't go there, and they should. Just last week, the Society for Hospital Medicine won the Eisenberg Award from the National Quality Forum for their work in mentored implementation, and I was very impressed with that. We're going to try to implement that into our own collaborative next year, but it's just these areas where there's huge gaps that I think should be identified by promotions committee and enhanced.
I think the issue is very discipline specific, and some disciplines are much further ahead than others are. I also think it's actually self-defeating to say that this kind of research doesn't lead to publications, and that I think it really does. And I think that they don't have to be mutually exclusive endeavors, and that that we can publish these things if we frame them appropriately.
In the back.
Thank you. I was wondering if you could speak a little bit to the best methods or approach in engaging communities in implementing findings, and also, the findings that are actionable, and also what sort of infrastructure you think might be necessary in order to engage different players, whether it's community physicians and health systems, earlier in the process of developing protocols.
Just to clarify, are you speaking of communities of caregivers, healthcare communities, or
Healthcare communities as well as healthcare recipients, both.
Well, I would answer that by saying the first most obvious thing is funding. That this is something that's interesting, but if there's no funding to support it, it's not going to happen. And that's where it's been so helpful to have our partners at Blue Cross Blue Shield who would say, we want you to do this, we value your input, and it is not going to cost you a dime to do this. Then I think that really gets people interested in participating. And then I think the second thing is this issue about providing actionable information relatively quickly. And that, in our group, to give you an example, and maybe I shouldn't use this example because it's right before lunch, and one of the things we found out as general surgeons is the best way to prepare your colon prior to colectomy is something we learned. And it's not maybe an appetizing subject, so I won't go there, but it's something that's quite actionable. And then we made 2,000 little laminated cards detailing how this should be done. We pass it out to everybody all over the place. And that, I think, when they see that kind of thing, then it gets them interested in the next project.
One quick comment that I see here at Michigan, our natural choice when we're thinking specifically about racial and ethnic minority communities is we go to Detroit or we go to Flint. And I would say be creative. If you go to a community that has less researchers chasing every patient down, you can get a lot of enthusiasm. When you go to communities that are much more congested, every negative experience that they've had with the University of Michigan precedes you and blows back on how you're perceived. And it's just, I would suggest go to Jackson, go to some of the other smaller communities in the western part of the state, and there's often a lot of receptivity and enthusiasm for finally being contacted and recognized when they usually are not.
in the back again?
Hi there, Matt Davis from Pediatrics, Internal Medicine, and the Ford School of Public Policy. Thanks to all of you for your comments this morning. I wanted to ask you to reflect on a situation you may have experienced where you'll see someone quoted or interviewed about a policy topic on which you feel that you have something to contribute, perhaps a different perspective, or perhaps a more informed perspective. Yet you were not the one contacted for that interview. How do you approach that, and what recommendations would you have for researchers in this audience if they find themselves in that situation?
So Matt, who's one of these people who's highly rated on LexisNexis because he's quoted all the time, he might have opinions on that as well. The first thing I'll point out is what Gary had said is there are resources like we have for government affairs. There are also resources for public relations to allow you to get your name out there. And as David Gifford clearly articulated, if you're going to wait for people to call, they're not going to call. So Kara Gavin's in the room, and her staff from the university does an amazing job. If you approach her with an idea, and just like the NIH, she'll think your idea is worthy for the news or not, and she'll give us the same rejection we're accustomed to from funding agencies to move that forward. And I think that you'll find that the things that are most interesting to the NIH are often the ones least interesting to Kara. So that kind of aligns, I think, to some of David's comments about this misalignment between what people want to know right away and what researchers communities do. But these are skills, Matt, as you know, that we'd never learned through the entire training process. And if you're lucky enough to have someone like Gary who put a protocol in place, or people in internal medicine where I am who made it very clear that you could publish and you could still perish, you could make that happen. And what you'll find is that the resources that we have, and whether it be the local reporters from the Michigan Daily to the AnnArbor.com up to the Detroit Free Press and News, to the national organizations, that people like Karen and her team know those reporters who are interested in your subject area. But what I'll say is what you want me to say, Matt, is if you don't step forward and get your name out there, although it may seem a bit arrogant, David, in that regard, it's never going to happen. So if you build it, they might come.
Did you have, go ahead.
I think it's a great question, and I think it happens to some of us more than others because we think we're experts on everything, and when we see someone else quoted, we wonder, well, why wasn't it us? And I think that a lot of people struggle with that. I think sometimes we're not going to get quoted on everything that we know more about than whoever gets quoted on. I mean, I think that's just the nature of the beast, and that's going to happen. But I do believe that while one can't address those individual instances, I don't think in a real meaningful way, is that the best bet is to let that particular instance drive an editorial to a particular newspaper that gets your point of view out, that gets it different, that makes it happen. And I think that different people have been more successful than others in doing that. I mean, I think there's a lot of stuff out there that we think, my God, why did they ask them? And what in the world did they say? And how goofy of them to say that. And, you know, I can only imagine that some people think that about me if I ever get quoted as well. So I think it kind of cuts both ways. But I think the more you can publicize what you do and get out an editorial when you feel that there's another voice out there that needs to be said is the way to do it.
David Gifford from AHCA. Sort of a follow-up question. I'd like to reiterate, Gary, some of the comments you made and hear maybe your response to this. I actually oversee a $1.5 million research budget. And so we're giving out money in $50,000 to $200,000 grants for people to do stuff, but we need it fast. We're evaluating a bill from Congress that's going to say they're going to change payment. Big policy question. We need it done. We don't need the 10th regression. But we don't care if you can publish it later on. So, and we're usually looking for, we use Inside the Beltway Bandits. Yeah. And they're expensive, and frankly, the reports that come out, no one believes. They would rather come out from an academic. We'd rather partner with the academic. But most academics, it takes the entire time just to get it through ORA. And it comes late, and they want to ask a different question. And we don't, again, care if they publish it. We actually have the data. We'll give you the data, but there's certain data use agreements with it. How do you sort of tackle that? And how do you get, sort of the question for promotion too, how do you make sure that there's credit for the junior faculty who spend time doing this? Because many of the analyses and questions that we have are the exact same thing that you'd see published in a journal 2 or 3 years later, but there was a report issued somewhere in Washington on it from a specialty society.
I think most academics are not set up to do this, period. And I do think, though, that there's some things that other people want done that they call us to ask us to do that we say no, because they're not necessarily of any interest to anyone in our group. We're not a Beltway bandit. And this is a struggle that we have often, is how big do we get? How much of a service do we provide to anyone who wants to come? Because then if that's what we're going to be doing all the time, then we're no different than RTI or Battelle, and will cost a lot more, just like you say that they do right now. So I think there's got to be a marriage of interest and the ability to get stuff done on time. And I think the only way you can protect junior faculty is being able to have senior people who will manage this kind of business flow, to be honest with you, because that's what it is. And for those junior faculty that can get benefit from doing that in terms of turning those things into publications, you may not care that they're going to be published next year, but you're going to need information now. The key is how to be able to allow you to use it and preserve the right for publication. I think that all can be done. I think sometimes it's a little tricky, but I think that there's ways of working with journal editors to make that happen. But I think sometimes you're going to have to go to the not-for-profit or the for-profit research companies because of either the nature of what you want or the nature of the people you're trying to work with. The other thing is that some people who want to fund those kinds of studies, and I don't know anything about what you do, they want a particular answer. They want you to do a study to show that pediatric cardiologists are better than adult cardiologists in the care of kids. Well, we're not going to do a study to show that. We'll do a study to see if, but that's where we separate ourselves out from the advocates, because they want a particular answer. And if we're not a priori willing to do that, that's part of the agreement we have with them, is that we're going to be public with whatever we find, whether it supports what you want it to support or doesn't support what you want it to support. And that scares people away to some of those other companies who will give them what they want.
There's a really, really important discussion that absolutely must happen at very high levels in academia, and it relates to your question. It relates to what Dr. Atkins said before about changing the incentives of how academics are evaluated. I mean, as a mentor, I cannot recommend to a junior faculty member that they go after something that's $50,000 from a private foundation. I just got back from Baylor Medical College, and someone there told me that you need 2 R01s, NIH R01s, to be promoted to associate professor. Now, if you're on a tenure track, as you know, and you don't get appointed to associate professor, you lose your job. You must leave. That's, that's a catastrophic outcome for someone. So it's absolutely essential that that person get to that point, and anything that's going to put that at risk, you just can't recommend. So, for me, now I can afford that. I've been promoted. I can afford to take grants from Blue Cross Blue Shield when they're available, or from the Office of Rural Health in the VA, but I get very, very little credit, even if they're millions of dollars, and something small from a foundation isn't going to cut it, even though it should. So that's a decision about how things are evaluated in academia that, like I said, we're just not going to be able to completely address this issue. There's a misalignment of incentives, and it's at the highest levels. It has to be discussed.
That's really good that we're scratching through the surface of some of these important barriers to partnering effectively. We have time for one more comment or question, if there is one. Going once, twice? Seeing none, then I'll say thank you very much to the panelists and to the audience, and we'll move on.